recording. Hi, I'm Burkhard Sievers, professor of medicine, specialized in cardiology, vascular medicine, gender medicine, and also board member of the German Society of Gender-Specific Medicine. Gender medicine is gaining more and more attention in Europe and especially in Germany. The country where it all came from is the USA, and there is the most experience regarding gender medicine and also in setting up the gender programs. And one of the experts is Gina. So today I'm talking to Dr. Gina Lundberg. And hi, Gina, it's great having you.
Well, thank you. It's nice to be here.
Yeah, thanks a lot. So can you please introduce yourself and tell us a little bit about you?
Well, I am a professor of medicine at Emory University School of Medicine in Atlanta, Georgia. And I am the clinical director of the Emory Women's Heart Center. It was founded in 2013, and I've been the founding and original director. Of course, Emory University is well known for our pioneer in heart disease in women, Dr. Nanette Wanger, and she is our founding consultant and has really been a pioneer in the area, and it's a real joy and a pleasure to work with her. My background in heart disease in women actually started in 1998 when I started the first women's heart program in the state of Georgia. It was a private practice model, and then we extended to a large hospital that delivers an awful lot of babies and does a lot of women's health, Northside Hospital. And then I took over as the founding director of the Women's Heart Center at St. Joseph Hospital, which later became part of the Emory campuses. So I've been doing this a very long time. I'm very clinically focused. We have some research projects, and our director of research is Dr. Pooja Mehta at Emory University. But I'm the clinical director, and we have a multi-specialty group of cardiologists and nurses and nurse practitioners who are focused on gender-specific medicine for women with cardiovascular disease.
Well, thank you so much. So you're really a woman of the first hour, right? So you were, as you lined out, so you're passionate about women's cardiovascular health, and you started the first women's heart program in Georgia. So please tell us, where's your interest, your strong interest in women's heart disease coming from?
Well, I had been out of my cardiology training about 4 years. I was doing a lot of general cardiology and preventive cardiology. And again, this is before we had Go Red for Women or Red Dress movement. And I just saw a woman after woman patient who had really been kind of marginalized and dismissed. Many women who had chest pain episodes, had been to the emergency room, and not had even had an EKG or referred for an exercise stress test. And then we would find they had cardiomyopathy or ischemia, blocked arteries in the heart causing the chest pain, and they really had just never even been taken seriously. As I was sort of noticing this in my clinical practice, I heard of another women's heart program that was focused on heart disease in women, and I really felt like, gosh, there's such a need for this. We need people who really focus on this. When I told my colleagues I wanted to start a women's heart program, and again, this was 1998, there was a lot of kind of laughing and snickering of, oh, you're just going to take care of all the palpitations and the hysterical females and, you know, the non-cardiac chest pain. And clearly that's not true, as we know. And it's been a wonderful journey. I'm glad I did it. It's been my passion, and I've seen a lot of growth and progress, but I still see a lot of needs. In fact, just this weekend on call, there was a woman with chest pain and a lot of shortness of breath symptoms. And when I finally got asked to see her, they hadn't even done an EKG. So there are days where I feel like we're making great progress, and then there are days I feel like we're back at square one, and then we still have so much to do.
Yeah, and you started at in 1998, and we are so far behind in Germany. So we're just starting now with the Women Heart program. So let me ask you this: what does it need to start a Women's Heart program? Can you give us some valuable advices how to start the programs?
Well, you know, when we first started, we were just focused on coronary artery disease, finding women with blocked arteries who are having chest pain symptoms or shortness of breath. But I've seen it explode into what we now call cardio-obstetrics. This is maybe a woman who already has heart disease, having a high-risk pregnancy, or a woman who has not had previous heart disease, but she gets into a pregnancy and now she's having a heart muscle weakness, cardiomyopathy, or an arrhythmia, atrial fibrillation that has been brought on during the pregnancy. This is a whole expanding field, and some women's heart programs are just focused on cardio-obstetrics. But we're also seeing women with the type of chest pain, angina, that's not coming from a blocked artery, what we call non-obstructive coronary artery disease or ischemia. And that's women who get chest pain maybe with stress or with exertion or from spasm in an artery. That, again, is a whole nother field. And we're seeing women with rheumatologic disorders having more cardiovascular problems. Women who've been through cancer treatments or survived cancer are now having serious cardiovascular problems, in part from the treatment, but also all the stress and the changes in their lifestyle that happen while they're going through cancer. So it's really just growing in every area. At the Emory Women's Heart Center, we have experts in hypertension, in what we call microvascular disease, cardio-obstetrics, cardiomenopause, the rheumatologic disorders, the autonomic dysfunction disorders, POTS or postural orthostatic tachycardia syndrome. We've seen an awful lot of that since COVID. We're just growing in 10 different directions. Yeah, so I wrote a paper in 2018 with several colleagues who run women's heart programs that was published in Circulation on what it takes to start a women's heart program. And, you know, it was very focused on awareness, treatment, and what we really need is guideline-directed medical therapy. We updated that paper just recently in Current Trends in Cardiology, and we had so much more that we need, you know, culturally appropriate education. We need patient education. We need flexibility in scheduling. Women may be caring for aging parents or small children, balancing career, and it's hard to get to that doctor's appointment. There's so much more that we need to really have a comprehensive women's heart program. In Germany, if you start anything, it'll be precious and valuable, but you'll find as you grow that there's so many needs, because the gender roles of women make their lives very complicated, right? They might be caring for children, parents, working. They may have adopted children. They may have a spouse with health issues. There's just so many things going on in a woman's life that it can be really hard for her to get the care she needs.
Yeah, that is so true. You know, Gina, let's come back to the program in your hospital. So it seems that it is very interdisciplinary, with all the other colleagues coming together and taking care of the woman's gender and the woman's diseases. So how do you train your medical staff in gender medicine, or especially in women's heart disease?
Well, we do have special rotations for medical students, medicine residents, and cardiology fellows to get the proper education on heart disease in women. But we also very much are about our own education. So every year, we've had 16 years now of the Emory Women's Conference on Heart Disease in Women. And we focus on new areas, whether it's in heart failure or electrophysiology or imaging, so that we can educate our team. We try to be aware of the latest breakthroughs and the latest research that's specific to women. Every 2 months, we have a gender-specific sex biology conference where we have researchers throughout Emory present their research, and we learn. We spend a lot of time collaborating. We also have a quarterly meeting that, because of COVID, has gone to a Zoom meeting like you and I are having, but where we engage on upcoming projects. You know, February's Heart Month. We usually do things with the public then. We have our medical education program in the summer. We're very active at American College of Cardiology and the American Heart Association. With we're going to have 2 abstracts at ACC in 23 in March in New Orleans. So we just have a very dynamic team, and we're constantly collaborating, working with each other. But we also work with the School of Nursing and the School of Public Health. So we're across silos so that we're all engaging. We have a working group on cardio-obstetrics that's actually run by one of our nurse PhDs. And she's very focused on getting women in after a hypertensive pregnancy and getting follow-up. So we have a lot going on, but remember, we've had 10 years to get this going. And when I joined Emory, I had over 15 years of experience. So we're not really a new program.
Yeah, that sounds awesome. So that sounds that it has been growing a lot, and yeah, it sounds very complete in any aspect. So the other thing is the people, the women outside, they have to know about the program and also about the heart disease. So these women's heart programs are very important to provide specific treatment for the woman with cardiovascular risk or cardiovascular diseases. And you have actually, so I looked that up and I found out that you have 3 locations in Atlanta, and the awareness and information of the general population is very, very important, but still little. So in Germany, it's very, very little. And I think in the US, it also has to be a lot of information done. So there's still a big information gap to prevent women from getting sex and gender-specific care. But I think you researched about some new approaches and models. So can you tell us a little bit more about those?
Well, again, that's getting to be like, what do we need in the future? How can we engage more women? So again, having multiple locations really helps. If you have one clinic address, then geographically, that's going to limit a lot of women who can come. I know we're doing more things on Zoom and telehealth, but it's really hard to do a cardiovascular evaluation on telehealth because, you know, we still have this old-fashioned thing called a stethoscope, right? We have to put this on your chest and listen to your heart. We have to do an EKG tracing that we can see. And looking at someone's feed, examining their hands, looking in their eyes, these things all have to be accomplished in person. So telehealth is really not amenable to, and especially an initial cardiovascular consultation. So having different geographic locations really helps. And then having people who are experts in different area. If you have a specific problem, like if you're pregnant, then you need to see our cardio-obstetric specialist. And by having different, again, locations and times where they can meet, that really helps. You were asking, like, how do we get the word out? I think one thing that's really helping these days is social media. We're on Facebook, we're on Twitter, and particularly like when you have Women's Health Month or Heart Month in February in the United States, having things on social media really helps. But we also go out and talk to large women's groups. If we get invited to come to a book club or an organization, a corporate sponsorship, say for an industry that has a lot of women, like teachers or realtors, we've talked to those groups. Because awareness really is the key, right? The primary care doctor might send them, but more often than not, women find out about us through the internet and through social media or a contact of a friend who has seen one of our physicians.
Yeah, and then there are these typical risk factors we're always asking, or the doctors are asking the patients, is like hypertension, diabetes, are you a smoker, do you have high lipids, or do you have obesity? But there are these specific female risk factors for cardiovascular disease. At least in Germany, well, there are just a few doctors that are aware of these risk factors. So can you talk about the risk factors a little bit?
Well, I think it does help that the American Heart Association has focused on these, but so has the European Society of Cardiology. You all have a wonderful meeting there, Paris, Barcelona, wonderful cities. And so hopefully your physicians can take advantage of that. But in addition to what we know about are the sex specific things, okay? And what's the one thing that only a woman can do? And that's have a baby, or at least so far. So these complications are what we call adverse outcomes of pregnancy, developing high blood pressure, particularly eclampsia or preeclampsia, having gestational diabetes, or just a large baby, an infant over 9 pounds may have been undetected gestational diabetes. Preterm labor, early delivery, low birth weight baby. These are all indicators of a woman having problems with that pregnancy. And we now look at pregnancy as the first stress test on the heart. And sometimes when you're talking to a woman, 55, 60 years old about her pregnancy, she wonders, why is this cardiologist asking me about these pregnancies that were so long ago? But it's very informative. And when I talk to a woman who's having a new diagnosis of hypertension now, frequently we find out she had hypertension during a pregnancy 20, 25 years ago. So these are very important. And then the rheumatologic disorders, women with lupus, rheumatoid arthritis, psoriatic arthritis, we know that because of probably the inflammatory issues, that's an added risk for heart disease. Women with migraine headaches. We used to think it was just women who had aura with their migraine, but now it may be all types of migraine. These women have increased risk for cardiovascular disease. And some of the also not sex specific, but things that are often overlooked in women is anemia. It usually portends poorly for a woman with heart disease as well. So there's so many things in a woman's past and medical record that can indicate additional risk factors to worry about. And even when it comes to traditional risk factors, I see women who've been running a blood pressure, 140 over 90 off and on for maybe several years, but they just keep being told, oh, well, let's keep an eye on that, or, eat less salt, try to lose weight, exercise more. Women who have LDL cholesterols way above 130, 140, 150, but they're still being told, well, your HDL is good, so you have a good ratio. That's been out of the American literature since 2007. These are not new risk for women. These are just risks that aren't being implemented by primary care physicians because there's this bias that women don't have as much heart disease, or well, they get it 10 years later, so I don't need to worry about this woman in her, late 30s, 40s, early 50s. But that really is the time to find the risk factors and aggressively treat them. I tell women prevention is what we do between 40 and 60. And after 60, we're managing disease. So we need to get a lot more aggressive with these younger women, particularly with these very treatable risk factors.
Yeah, that's so true. And, menopause is one of these risk factors, and especially women in menopause who are struggling from severe symptoms regarding the menopause are often treated with hormones. And you recently published a paper about this that I read and that I found very interesting. Can you talk about this a little bit?
Yeah, that's actually one of my favorite subjects. So I've coined the phrase menopause cardiology, like we have, obstetrics and cardiology, because it's really important as a woman gets into her pre-menopause years to start to understand what are her risk factors and what is her family history. What has her cholesterol been doing? And generally it jumps in a very unfavorable way at menopause, right? The LDL gets higher, the HDL that may have been cardioprotective is now declining, the triglycerides are usually getting higher, women's arteries are getting stiffer, they're seeing more high blood pressure, they're putting on a little weight, they're getting more adipose tissue around their hips, waist, buttocks than they had before. And these are all normal changes for menopause. So I think it's important because nothing is better for vasoreactive vasomotor symptoms or even genitourinary symptoms than good old estrogen. There's nothing like it. But you need to be a low-risk woman to be able to take menopause hormone therapy, at least maybe up to 5 years or so, and depending on your risk, even longer. We don't want older women who've been years past menopause starting hormones. We look for things like serotonin boosters, that might help, or other ways to treat the vasomotor symptoms. But a woman in that, say, 48 to 51, 52-year-old zone who is acceptably low risk can use a hormone replacement safely. We prefer transdermal and low dose, not oral. Vaginal estrogen to make sexual activity or the genitourinary symptoms, more acceptable. That's fine. And sometimes I'll even have a woman who's really high risk, but she feels her quality of life is so altered that with an informed decision, with understanding the risk, we can still allow women to do this as long as they stay in close contact with us. So I wouldn't say hormones are an absolute no-no, but it needs to be modified very individually for each woman based on her risk. And when able, I think a coronary artery calcium score is very, very helpful in this population. If the score is 0 and her lipids look good and her blood pressure looks good and she has a healthy lifestyle and a normal BMI, then hormones might be the best treatment for those symptoms.
Yeah, so it's very personal and very individual, the treatment. So earlier, Gina, we talked about the importance also of research and what has to be done, what was done, and all these results. So what are the most surprising or exciting recent research findings for you regarding gender medicine?
Well, I have a large project focused on African American women here in the metro Atlanta area, and we've screened 1,000. And what we're learning is when you look at women 20 to 40 and 40 to 60 and 60 and higher, many of these women have already achieved an increased BMI that puts them at risk even in their 20s. And high blood pressure is there also in the 30, 40, 50-year-old women. These are the changes that we could implement, whether it's in better education in our schools and colleges, or better information through the OBGYN, who tends to be the primary care doctor for women of childbearing ages, that they've got to have healthier diets, exercise. And with some of the new drugs, the GLP-1 agonists, we are having tremendous weight loss safely and effectively in a lot of women whose BMI is over 35. So I'm very concerned about increasing obesity in the United States. I know you're also seeing it in Europe. I think that this is going to add to pregnancy complications in heart disease younger in women. And we've seen from the American Heart Association data that heart disease has been going back up, not only in women, but in men. And that the average life expectancy has stalled out for women in America and has actually taken a little decline. So I think the future is very worrisome if we don't do a better job of implementing good health earlier for these women. So that's what I'm really kind of fired up about, and where my passion is getting to younger women sooner with these really just public health messages, right? Exercise, eat healthier, keep your weight down. Very basic things.
Yeah. It always comes down to these basic things, but they are so important. So Gina, thank you so much for sharing your knowledge and also giving us a lot of insights of your work, what you do, your opinion, and your knowledge. So what a pleasure meeting you. Thank you so much for your time.
Well, thank you for having me. And I really hope that heart disease in women in Germany becomes very well known, and that women get great treatment through your efforts. Thank you.
Yeah, so I found my stethoscope and go ahead and start the program now. Okay, thanks a lot.
All right. Bye-bye.
Thank you so much.